Good evening everyone, myself Dr. Apoorva Mittal and I am your educator for Anesthesia on this prestigious platform of Unacademy. Friends, welcome to NEET PG Live Daily, and today we'll be discussing about the FMGE Previous Year Questions that has been asked. So welcome friends, welcome to today's class. And before starting the class, just let me tell you about the Unacademy Plus subscription. Okay, what are the advantages of the Unacademy Plus subscription? So friends, by getting the Unacademy Plus subscription, you will be able to avail the live classes for the 19 subjects, okay, which are important for you to crack NEET PG. And the live classes are structured in a way that it will tell you what all topics are important for what all exams, so that you have a foolproof idea like what to read and how to read. And also you'll be able to interact with the educator for the 19 subjects, the top educators. We are having daily test series and analysis in which you can evaluate your progress and come to know how the questions are asked and apply your theoretical knowledge into the clinical and the image based questions also. And also live doubt clearing sessions in which you can clear the doubt pertaining to the subject, okay, from the top educators. So these are all the advantages of the Unacademy Plus subscription. Okay, any doubts till now? Am I audible? Okay, so starting with today's topic, I'll be discussing about the previous year questions that has been asked in FMGE. Okay, so should we start with the session, friends? Please give me a thumbs up if we should start with the topic for today. Okay, fine. So the first question for today is high spinal anesthesia. Okay, the high spinal anesthesia, it is characterized by A. Hypertension and tachycardia, B. Hypertension or bradycardia, C. Hypotension or bradycardia, and hypotension and tachycardia. What should be the answer for this? High spinal anesthesia is characterized by hypertension and tachy, hypertension and brady, hypo and brady, and hypotension and tachycardia. What should be the answer for this, friends? High spinal anesthesia. I hope you all know what is high spinal anesthesia. So in that, what it is characterized by? Okay, I'm waiting for your answers. I'm waiting for your answers. Okay, friends. High spinal anesthesia. High spinal anesthesia, it is characterized by C, that is hypotension and bradycardia. It is characterized by C, that is hypotension and bradycardia. So first we should know why, what is high spinal anesthesia? What is high spinal anesthesia? What are the features of high spinal anesthesia? Dr. Sejal, welcome to the class. It is not A, it is C. Okay, let me tell you, let me clear the concept of high spinal. So what it is, what are the features of high spinal, what is total spinal, and what are the factors which determine the spread of the local anesthetic in spinal anesthesia. So what is high spinal anesthesia? First of all, high spinal anesthesia is when the local anesthetic, see, whenever we are giving local anesthetic in spinal anesthesia, what does it do? It causes sympathectomy. Okay, it causes sympathectomy of normally when we are giving local anesthetic, it causes sympathectomy of, okay, that is from T5 to L1 level. Okay, that is from T5 to L1 level, and there is peripheral, there is vasodilation because of this, and peripheral pooling of blood. okay, of blood, and that is responsible for hypotension. That is responsible for hypotension. Okay, so this hypotension in spinal anesthesia is because of the loss of tone of the vasomotor fibers, okay, of the vasomotor vessels, which causes the pooling of blood, and therefore it causes hypotension. Okay, now this is this. Now what happens in high spinal? What happens in high spinal? What happens? The local anesthetic, okay, the local anesthetic, it blocks the local anesthetic, it blocks the T4 fibers that are cardio accelerator fibers, that are cardio accelerator fibers. ठीक है, अगर T4 से नीचे था, ठीक है, सिंपैथेक्टमी, तो क्या हो रहा था कि ऊपर के जो कार्डियो एक्सेलरेटर फाइबर्स थे वो हार्ट रेट मेंटेन कर रहे थे, मगर हाई स्पाइनल का मतलब क्या हुआ कि उसका जो इफेक्ट है लोकल एनेस्थेटिक का वो ऊपर तक चला गया और उसने T4 लेवल के फाइबर्स को भी ब्लॉक कर दिया. That is, the cardio accelerator fibers are also blocked, and therefore patient has bradycardia. Dr. Sejal, is it clear? It's okay if you are in second year. That's why we are here to help you out, to help you with the concepts. Okay, so spinal anesthesia, what it is? The spinal anesthesia is, after we give the local anesthetic in spinal anesthesia, it causes sympathectomy. Sympathectomy होगा तो क्या होगा? The loss of the vasomotor tone. There is loss of the vasomotor tone. Vasodilation होगा. उसकी वजह से peripheral pooling of the blood होगा. Venous return. Okay. Because of the peripheral pooling of the blood, there is hypotension. Are you understanding my point? Now, हाई स्पाइनल में क्या होता है? हाई स्पाइनल में क्या होता है कि जो स्पाइनल का इफेक्ट होता है, लोकल एनेस्थेटिक का इफेक्ट होता है, वो ऊपर तक चला जाता है. इट इज ब्लॉकिंग द T4 फाइबर्स ऑल्सो. ठीक है, दैट आर द कार्डियो एक्सेलरेटर विच वॉज मेंटेनिंग द हार्ट रेट, एंड देयरफॉर in high spinal patient has both bradycardia and hypotension. So what it is, I told you, if the spinal anesthetic is above the level of T4, then it causes hypotension and bradycardia. Dr. Ehsan and Dr. Sejal, welcome to the class. Is it clear? Dr. Ehsan Ali, welcome to the class. So this is about the high spinal. Now, how is it different from total spinal? Okay, how is it different from total spinal? Total spinal anesthesia, remember, high spinal, okay, high spinal is different from total spinal. It is different from total spinal anesthesia. ठीक है, हाई स्पाइनल में तो मैंने बता दिया कि अगर T4 से ऊपर, above T4 the fibers, there is block. Above T4 there is block, and therefore we have these features. In total spinal anesthesia, what happens? The cranial nerves get involved. ठीक है, and therefore there is total spinal anesthesia. Okay, now what are the factors? One more question. What are the factors that determine the spread of local anesthesia? ठीक है, the factors that determine the spread of local anesthesia, that means जब लोकल एनेस्थीसिया दिया है तो वो कितने लेवल तक जाएगा, what are the factors which are determining it? So there are factors related to the drug. Okay, then in the drug it depends the potency of the local anesthetic which is used. Okay, the volume of the local anesthetic that is used, and the dosage of the local anesthetic that is used. So these are the factors which are related to the drug. How much potency, how much volume, how much dosage we are giving. Okay, and one more thing, the patient factors. The patient factors on which it depends is the age of the patient. ओल्ड एज, ठीक है, ओल्ड एज में क्या होता है, ओल्ड एज में क्या होता है, देर इज लॉस ऑफ द, देर इज जो स्पेस होता है, द सब एरिथ्मोइड स्पेस होता है, वो कब छोटा हो जाता है, वो नैरो हो जाता है, ठीक है। एंड सो देयरफॉर वी नीड इन ओल्ड एज वी नीड less drug to produce the effect. What happens in pregnant ladies? What happens in pregnant ladies? Pregnant ladies में स्पेशली थर्ड ट्राइमेस्टर में क्या होता है, यूट्रस, ग्रेविड यूट्रस वो क्या कर रहा है, it is compressing upon the subarachnoid space, and as it is compressing the subarachnoid space, the the space is narrower and therefore we need less amount of drug. जैसे फॉर एग्जाम्पल अगर नॉर्मल पेशेंट में हम लोग 4 ml दे रहे हैं, तो प्रेग्नेंट लेडीज में हम लोग सिर्फ 2.5 to 2.8 ml देंगे एंड वी विल गेट अ गुड इफेक्ट, बिकॉज इन प्रेग्नेंट लेडीज ये जो ग्रेविड यूट्रस है वो कंप्रेस कर रहा है सबएरेक्नोइड स्पेस को और वो नैरो हो रही है, एंड देयरफॉर वी नीड लेस अमाउंट ऑफ ड्रग टू प्रोड्यूस द इफेक्ट. डॉक्टर सेजल और डॉक्टर एहसान, इज इट क्लियर? ठीक है. सो द पेशेंट फैक्टर्स, द एज ऑफ द पेशेंट, द प्रेग्नेंट लेडीज, द हाइट ऑफ द पेशेंट. ओके, हाइट ऑफ द पेशेंट, अगर पेशेंट की हाइट छोटी है तो देर आर मोर चांसेस ऑफ कैपिलर स्प्रेड ऑफ द ड्रग, and therefore we have to use lesser amount of drug in case of the shorter height patients rather than the patients who have a good height. Is it clear? So what is high spinal? High spinal में क्या होगा, if the cardio accelerator fibers are also lost, so therefore there will be bradycardia and hypotension, and therefore it is C is the answer. Is it clear? Any doubts in this question? And spinal anesthesia, because of the peripheral pooling of the blood, there will be hypotension. Okay, now coming to the next question for today, the post-spinal headache. Okay, post-spinal headache can be prevented by A, thinner needle, B, early ambulation, C, induced hypertension, or D, decreasing dosage of the anesthetics. What can the post-spinal headache can be prevented by? Thinner needle, early ambulation, induced hypertension, or decreasing dosage of anesthetics. What should be the answer for this? I'm waiting for the answer. Dr. Ehsan, Dr. Sejal, I advise you to please go through my regional anesthesia lectures, in which the concept of the spinal anesthesia and the epidural anesthesia will be clearer to you, and you can easily solve all these questions. Okay. So post-spinal headache can be prevented by, what is the answer? Dr. Sejal, Dr. Ehsan, others, anyone else? What should be the answer in this? Okay, fine. Post-spinal headache. After giving the spinal anesthesia, if the patient has headache, it can be prevented by, remember, thinner needle. Okay, it can be prevented by A, using thinner needle. Now, what is post-spinal headache? Why does it occur? What are the characteristic features? Okay, what are the aggravating features? And what is the duration after the spinal anesthesia, and what is the treatment? So, what is post-dural puncture headache? Okay, what is post-dural puncture headache? So, that is PDPH. What it is? See, this, as the name suggests, after the puncture of the dura, patient is having headache. So in spinal anesthesia, we are puncturing the dura. Dr. Sejal has given me D as the answer. No, Dr. Sejal, it is A. Let me tell you what is post-dural puncture headache. The post-dural puncture headache is because of breach. Okay, because of breach in dura. ठीक है, in dura matter, because of the breach in the dura matter, there is leakage. Okay, there is leakage of CSF through it. ठीक है, through it, and that is causing headache. So this is post-dural puncture headache. तो spinal anesthesia में क्या होता है? We are piercing the dura matter. ठीक है, वी आर पियर्सिंग द ड्यूरा मैटर. तो अगर हम लोगों ने जैसे ड्यूरा मैटर थिकर निडल से, ठीक है, मोटी निडल से अगर हम लोग उसको पियर्स करेंगे तो क्या होगा? मोर चांसेस ऑफ CSF लीक, right? And this can be prevented by, therefore this can be prevented by what? It can be prevented by using first thinner needle, and secondly, instead of dura puncturing needles, ठीक है, जो ड्यूरा को पंचर करके जाते हैं, what if we just separate the fibers of dura matter? So this can be prevented by using thinner needles and dura separating needles. Is it clear? Are you getting my point? Instead of piercing the dura को cutting needles, which is dura cutting needles, for example, dura cutting needles कौन सी होती है? Dura matter cutting needles are, okay, cutting needle is quincase, ठीक है, quincase needle. तो क्या होगा? Quincase needle, the spinal needle which we most commonly use, it will cut the dura. तो उसकी वजह से there are chances कि CSF leak हो. What if we use dura separating needles, which are just separating the fibers of separating needles, which are just separating the fibers of the dura matter, like Whittaker and Sprott, okay, Sprott needle. Okay, so these are the methods by which you can reduce the post-dural puncture headache, which you can remove the post-dural puncture headache. Now, because of the CSF leak, why there is headache? CSF leak हो रहा है तो क्या होगा? There will be traction on the brain and its membrane, and therefore there is headache. Now, ये जो headache होता है, it is characterized by usually, okay, it starts within 24 to 72 hours. ठीक है, आफ्टर स्पाइनल एनेस्थीसिया. ठीक है, आफ्टर स्पाइनल एनेस्थीसिया ज़्यादातर 24 to 72 आवर्स के बाद हम लोग देखते हैं कि ये हेडेक शुरू होता है. इट इज़ इन यूजुअली ऑक्सीपिटो फ्रंटल रीजन. ठीक है, ऑक्सीपिटो फ्रंटल रीजन. एंड वन मोर इम्पॉर्टेंट थिंग इज इट इज एग्रवेटेड. ठीक है, एग्रवेटेड इन सिटिंग और स्टैंडिंग पोजीशन. ठीक है, ये बात याद रखना. ये जो पोस्ट्यूरल पंचर हेडेक होता है ना, it is aggravated in sitting or standing position, and it is relieved in lying down position. So please remember this point. This is very important point. Duration 24 to 72 hours पे it will start, and it can be seen till 1 week also. ठीक है, are you getting my point? Any doubts in this? ठीक है, so this is post-dural puncture headache. Now what will be the treatment? What should be the treatment? the treatment of the post-dural puncture headache is, क्या हो रहा है, CSF का formation is less than the CSF का loss, right? So the first and the foremost treatment should be to give IV fluids. Okay, the first and the foremost treatment should be to give IV fluids. In fact, the treatment of choice, okay, if it is asked, the treatment of choice, that is IV fluids, that is IV fluids. The other things that you can do is you can give caffeine to the patient, you can give NSAIDs, ठीक है, NSAIDs, caffeine to the patient, but the first and the foremost thing is you should give IV fluids to the patient. Okay, the third, the definitive treatment, अगर patient का headache अभी भी ठीक नहीं हो रहा है, with the IV fluids, with the symptomatic treatment, the third thing you can do is go for epidural patch. Go for epidural patch. Now what is epidural patch? What is epidural patch? क्या होता है कि because what is happening, because of the breach in the dura, there is constant leak of the CSF. What if अगर हम उस एरिया का जो वो है ब्रीच है, उसी को हम लोग बंद कर दें, उसी को हम लोग बंद कर दें, तो दैट कैन बी डन विद एपिड्यूरल पैच. इसमें क्या होता है, रिमेंबर इन एपिड्यूरल पैच पेशेंट का ही, ठीक है, पेशेंट, द ऑटोलॉगस ब्लड फ्रॉम द पेशेंट अराउंड 15 to 20 ml इज टेकन फ्रॉम द पेशेंट, और ये ब्लड हम लोग ऊपर, जैसे अगर हमने L3 L4 लेवल पे स्पाइनल दिया था, तो उसके एक लेवल ऊपर या फिर L3 L4 लेवल पे ये ब्लड को इंजेक्ट कर देंगे इन द एपिड्यूरल स्पेस, ठीक है, इन द एपिड्यूरल स्पेस. तो क्या होगा, ये ब्लड वहां पे क्या हो जाएगा, क्लॉट हो जाएगा, एंड दैट विल प्लग the breach in the dura, and that will prevent further loss of the CSF. Is it clear? Is it clear? Any doubts in this? Dr. Ehsan, Dr. Sejal, is it clear? Any doubts in this? So this is about the treatment of, this is about the treatment of the post-dural puncture headache. Okay, this is about the treatment of post-dural puncture headache. Should we go to the next slide? Should we go to the next question? Now, the next question is in spinal anesthesia. Okay, in spinal anesthesia, the first nerve to get blocked is, okay, spinal anesthesia में the first nerve to get blocked is A, autonomic preganglionic fibers, B, temperature fibers, C, somatic motor fibers, or D, vibratory and proprioceptive fibers. What should be the answer for this? In spinal anesthesia, the first nerve to get blocked is autonomic preganglionic, B, temperature fibers, C, somatic motor, or D, vibratory and proprioceptive fibers. Could you please tell me the answer? I'm waiting for the answer. Spinal anesthesia देते हैं, तो which is the first nerve to get blocked? Okay, Dr. Ehsan Ali is asking me to repeat the epidural patch. I'll just repeat it. Please let me know the answer for this question, and then I will repeat the epidural patch. Okay, I'll repeat the epidural patch. Just tell me the answer for this question. After that, I'll repeat it. Okay, in spinal anesthesia, the first nerve fiber to get blocked. No, it is not vibratory and proprioceptive. It is not somatic motor fibers. It is A. It is A, that is autonomic preganglionic fibers. It is A, which is autonomic preganglionic fibers. So, before discussing this question, let me clear your doubt on the epidural patch. Okay, let me clear the doubt on the epidural patch. Okay, now epidural patch. See, what happens? There is breach in dura mater. ठीक है, अब ड्यूरा मैटर्स में अगर कुछ ब्रीच होगा, ठीक है, कुछ डिसकंटिन्यूटी होगी, तो उसकी वजह से द CSF is leaking. The CSF is leaking. Now, because of the leakage of the CSF, there is traction on the brain and the nearby tissue, and therefore we are getting the headache. ठीक है, पहले हम लोगों ने IV फ्लूइड्स दे दिया, उससे कुछ काम नहीं बना. दूसरा हम लोगों ने उसको कफीन दे दिया, NSAIDs दे दिया, सिम्टोमेटिक ट्रीटमेंट दे दिया, उससे कुछ काम नहीं चला. तो हमारा लास्ट रिसोर्ट क्या होगा? लास्ट रिसोर्ट इज टू गिव द एपिड्यूरल पैच, is to give the epidural patch to the patient. Now, what is epidural patch? That is, in epidural patch क्या कर रहे हैं? Autologous blood. Autologous blood मतलब पेशेंट का खुद का ब्लड अराउंड 15 to 20 ml हम लोग कलेक्ट करते हैं. ठीक है, ये ब्लड हम लोग क्या करते हैं? हम लोग एपिड्यूरल स्पेस, ठीक है, एपिड्यूरल स्पेस में इंजेक्ट कर देते हैं. ठीक है, उससे क्या होगा? ये जो ब्लड है, इट विल गेट क्लॉट. ठीक है, and this clot will cause what? उधर एक पैच बना लेगा. ठीक है, ये क्लॉटेड ब्लड वहां पे क्या करेगा? इट विल प्रिवेंट, ठीक है, एक उसमें क्या, उसको बंद कर देगा, उस ब्रीच को. इट विल क्लोज द ब्रीच. ओके, इट विल क्लोज द ब्रीच in the dura, and therefore no more loss of CSF will be there, and that will be the treatment for the post-dural puncture headache. But remember, if it is asked what is the treatment of choice in post-dural puncture headache, it is always IV fluids. It is always IV fluids. It is not epidural patch. Epidural patch we are giving if at all we are not able to take, मतलब अगर patient is still symptomatic even after giving the IV fluids, even after giving the symptomatic treatment. Now is it clear? ठीक है, so this is what is epidural patch. एपिड्यूरा में हमने एक पैच लगा दिया, ठीक है, जिसकी वजह से वो जो ब्रीच था जहां से CSF लीक हो रहा था, वो अब लीक नहीं होगा, and therefore that is the treatment for PDPH. Dr. Ehsan, Dr. Sejal, is it clear now? Okay, fine. I hope I have made it clear. Okay, now, so we were discussing the question number 3, that is, in spinal anesthesia, the first nerve to get blocked is A, autonomic preganglionic, temperature, somatic, or vibratory. So the answer is autonomic preganglionic. How we will remember this? See, according to this you would have read in physiology. Okay, ये physiology में पढ़ा होगा. Physiology में you would have read about Erlanger and Gasser classification. Okay, Erlanger and Gasser classification of nerve fibers depending so the nerve fibers, the function of the nerve fibers, okay, the diameter of the nerve fibers, and whether they are myelinated or not. ठीक है. So depending on this, Erlanger and Gasser, they classified the nerve fibers into, broadly classified into A, B and C type. Okay, they broadly divided it into A, B and C type. Now the A nerve fibers, these are large diameter, they are large diameter nerve fibers, but they are myelinated, they are myelinated. ठीक है. जो बी वाले फाइबर्स होते हैं, दे आर मीडियम, ठीक है, दे आर मीडियम डायमीटर नर्व फाइबर्स एंड दे आर पार्शियली माइलिनेटेड. ठीक है, सम ऑफ देम आर माइलिनेटेड, सम ऑफ देम आर नॉन माइलिनेटेड. C fibers, they are small fibers, but they are unmyelinated, ठीक है. So the nerve fibers depending upon the diameter and the myelination, they are in turn divided into A, B and C type. ठीक है, depending upon the diameter A fibers, ठीक है, A सबसे बड़े fibers and they are myelinated, Dr. Ehsan is asking me, ma'am, please tell the causes if spinal anesthesia is failed. Let me just discuss this question with you and then I will take your doubt. Okay, the causes of the spinal anesthesia failure, I'll take it, but let me just, you know, complete this question. So the nerve fibers on the diameter, on the myelination, they are large, medium and small and myelinated or this. Now remember, local anesthetic को क्या करना है, ठीक है, लोकल एनेस्थेटिक को इसको पेनिट्रेट करना है. लार्ज नर्व फाइबर्स में इसको एक्ट करने में, लोकल एनेस्थेटिक को एक्ट करने में टाइम लगेगा. ठीक है, लोकल एनेस्थेटिक को एक्ट करने में टाइम लगेगा, राइट. तो इसलिए लार्ज नर्व फाइबर्स, दैट इज द ए नर्व फाइबर्स, दे आर लीस्ट सेंसिटिव टू लोकल एनेस्थेटिक्स. Now what about B and C? According to the diameter of the nerve fibers, C should have been more sensitive to the local anesthetics, but they are non-myelinated, they are unmyelinated nerve fibers. So the B nerve fibers, they are medium diameter, plus they are partially myelinated, and therefore they are more sensitive to local anesthetic than the C nerve fibers. So the fibers, okay, out of A, B and C, the most sensitive is the B nerve fibers, then it is C, then it is A. Are you getting my point? So you have to remember BCA. Okay, according to the sensitivity of the nerve fibers. Now, what are the functions? Okay, what are the functions? That is also very important. And then the A nerve fibers are in turn divided into 4 types. Okay, ये जो A nerve fibers है, the large nerve fibers, they are A alpha, A beta, A gamma and A delta. ठीक है, A alpha fibers, A beta fibers, A gamma and A delta. ठीक है, so what is the function of this? A alpha, okay, alpha, these are the ones, सबसे पहले, these are the ones which are responsible for motor and proprioception. Remember, ठीक है, A alpha fibers, ठीक है, alpha सबसे बड़ा, A alpha male, okay, they are responsible for the motor and the proprioceptive proprioception. A beta is touch and pressure. it is touch and pressure. ठीक है. A gamma it is muscle spindle. ठीक है. And A delta, okay, A delta it is temperature and pain. It is temperature and pain. Is it clear? So the A nerve fibers, they are in turn divided into A alpha, A beta, A gamma and A delta. A alpha it is motor and proprioception. ठीक है, motor. फिर उसके बाद touch and pressure. ठीक है, gamma is muscle spindle and delta is temperature and pain. इसको कैसे याद रख सकते हैं? ए अल्फा सबसे बड़ा है, ए अल्फा सबसे बड़ा है, तो मोटर, ठीक है, मोटर वाला फंक्शन, पूरी की पूरी मसल इन्वॉल्व है मोटर, उससे कम सेंसेशन क्या होता है? टच का सेंसेशन या फिर प्रेशर का सेंसेशन. उससे भी कम क्या होता है? टेम्परेचर ऑफ पेन. इवन अ स्लाइट टेम्परेचर ऑफ पेन विल कॉज the sensation. So motor, touch and temperature and pain. Okay, beta, B fibers and C fibers. B comes before C, so B is preganglionic autonomic fibers. Are you getting my point? B is preganglionic autonomic fibers. Is it clear? So B is preganglionic autonomic fibers. C, it is postganglionic. Remember, postganglionic autonomic fibers, and it also carries pain and temperature fibers. Okay, fast pain and temperature fibers. Is it clear? So these are the this is the classification of the nerve fibers, and this is the function of these nerve fibers. Now, so BCA, this is the sensitivity, और उसमें भी B more than C, more than A. A maybe it is reverse order, that is A delta is more sensitive. So the nerve fibers which are carrying temperature and pain are more sensitive than A beta, and the last nerve fibers to get is A alpha. कैसे याद रखोगे? जब भी हम स्पाइनल एनेस्थीसिया देते हैं तो उसका इफेक्ट जानने के लिए हम लोग हर समय पेशेंट को बोलते हैं अपने पैर उठा के दिखाओ. ठीक है, पैर अगर पेशेंट इज नॉट एबल टू लिफ्ट द लेग, what is that? That is the patient has lost the motor sensation, and if the patient has lost the motor sensation, that means the other sensation, that is sensory and autonomic, is also lost. Okay, so this is about the nerve fibers and the sensation. So autonomic, okay, autonomic, then sensory, then motor sensation is lost. First the autonomic sensation, then the sensory, then the motor. How will you remember this? You will remember this as ASAM. Okay, you will remember this as ASAM. सबसे पहले autonomic, फिर sensory, then motor. Is it clear? Is it clear? So this is the classification of the nerve fibers. This is the classification of the nerve fibers. Any doubts in this? Any doubts in this? So therefore, in spinal anesthesia, what is the first nerve fiber to get blocked? That is autonomic, ASAM, right? It is ASAM, it is autonomic preganglionic fibers, which is carried by what? Which is carried by the B type of nerve fibers. Which is carried by B type of nerve fibers. Is it clear? Any doubts in this? Now, Dr. Ehsan has asked me, ma'am, please tell the cause of if spinal anesthesia is failed. See, the cause of failure of spinal anesthesia, okay, it can be because of the drug, it can be because of the procedure, how we are procedure, how we are giving the spinal anesthesia, and sometimes it can be the patient factors also. So the drug is, if the drug is less potent, if the volume is not proper, if the concentration of the drug which we have used is less, then it can cause the failure of spinal anesthesia. Okay, if the needle, okay, if the spinal needle is half inside the subarachnoid space and half it is outside the subarachnoid space, okay, then also, या फिर while giving the spinal anesthesia गलती से needle displace हो गई है, उसकी वजह से भी spinal anesthesia का effect आना नहीं आ सकता. ठीक है. So because of the drug, because of the procedure, sometimes patient like kyphoscoliosis है, स्कोलियोसिस है या फिर काइफोसिस है, ठीक है, या फिर उसको पहले से ही कुछ न्यूरोमस्कुलर डिसऑर्डर्स हैं जहाँ पे हम इवैल्यूएट नहीं कर पा रहे, हमें स्पेस ठीक से नहीं मिल पा रही है. सो दीज कैन लीड टू द फेलियर ऑफ स्पाइनल एनेस्थीसिया. This can lead to the failure of spinal anesthesia. ठीक है. So these are the causes for the failure of spinal anesthesia. ठीक है. Now, question number 4. The local anesthetics, they act by inhibiting. The question number 4 is, the local anesthetics, they act by inhibiting A. Sodium channels, B. Potassium channels, C. Calcium channels, or D. Magnesium channels. What should be the answer for this? Local anesthetics, they act by inhibiting. Please tell me the answer. The local anesthetics, they act by inhibiting A. Sodium, B. Potassium, C. Calcium, or D. Magnesium. This you would have read in pharmacology also. Waiting for the answer. Okay. So the local anesthetics, they act by inhibiting mainly the sodium channels. Mainly the sodium channels. Okay. So they act by inhibiting the sodium channels. Remember. Now how they act? Okay, Dr. Ehsan has given A, right? Dr. Sejal, it is not potassium channel, it is sodium channels. Let me tell you how. How does local anesthetic works and why, how do they block the sodium channels? Now, first of all, local anesthetics, what are they doing? They are blocking the conduction of, they are blocking the conduction of nerve impulses. Okay, they are blocking the conduction of nerve impulses. Now imagine this is a nerve fiber which is in the resting membrane potential, Now what happens in resting membrane potential? यहाँ पे negative charge होता है, right? यहाँ पे positive charge होता है. Inside it is negative, outside it is positive. Why? Because outside sodium is more, inside potassium is more. ठीक है? And the negative ions that is more inside, and because of the sodium potassium ATPase pump, what it does is it pumps skin to potassium, but it pumps out 3 sodium. ठीक है. सोडियम पोटेशियम कैसे याद रखोगे? पम्पकिन. ठीक है, पम्पकिन होता है ना कद्दू, तो इट pumps into potassium, in turn of 3 sodium out. 3 sodium out. So therefore अंदर 2 ही पोटेशियम आ रहे हैं, उसके जगह 3 सोडियम बाहर जा रहे हैं. So therefore inside there is negative charge and outside there is positive charge. Now this is in the resting membrane potential. Now ये जो nerve fibers हैं, इसमें voltage gated sodium channels भी होते हैं. ठीक है, ये जो नर्व फाइबर्स हैं, दे हैव वोल्टेज गेटेड सोडियम चैनल्स. ठीक है, दे हैव वोल्टेज गेटेड सोडियम चैनल्स। तो क्या होता है, जब रेस्टिंग मेम्ब्रेन पोटेंशियल होता है, जब रेस्टिंग मेम्ब्रेन पोटेंशियल होता है, ये जो सोडियम चैनल्स हैं, दीज आर क्लोज्ड। Okay, these are closed. Dr. Vikrant, welcome to the class. Okay, these are closed and therefore इसके अंदर से सोडियम अंदर नहीं आ पाता, सोडियम अंदर नहीं आ पाता। जब इसमें इम्पल्स आता है, जब इसमें इम्पल्स आता है, ये जो सोडियम चैनल्स होते हैं ये ओपन हो जाते हैं, ये ओपन हो जाते हैं और उसकी वजह से सोडियम का इन्फ्लक्स हो जाता है एंड देयरफॉर what will happen, there will be positive charge inside and negative charge outside. Whenever there is impulse generation, what happens, there is opening of these voltage gated sodium channels. Okay, and therefore the sodium influx happens. Yes, Dr. Ehsan, I'll just tell you that there is opening of the sodium channels and therefore positive charge inside, negative charge outside, that is depolarization of membrane happens. Therefore there is depolarization of membrane. Understood? Now अब क्या होता है, अब क्या होता है, जब हम लोगों ने लोकल एनेस्थेटिक दिया, जब हम लोगों ने लोकल एनेस्थेटिक दिया तो क्या होगा, ये इन नर्व फाइबर्स को पेनिट्रेट करेगा, ठीक है, एंड इट विल ब्लॉक दिस सोडियम. Okay, it will block this sodium, it will block this sodium channels and therefore further influx of the sodium cannot happen and therefore they block the conduction of nerve impulse. Is it clear? Is it clear? Dr. Ehsan has rightly said they block the inner gate of the sodium channel. ठीक है, they block the inner gate of the sodium channel. I'll come to that point. First I'm just telling मोटा मोटा कि क्या हो रहा है, ठीक है. तो डॉक्टर सेजल, it is blocking the sodium channel, it is blocking the inner gate of the sodium channel, it is blocking the sodium channel from the cytoplasm, ठीक है, from the cytoplasmic end. Now first of all ये जो सोडियम, so it acts by inhibiting sodium channel, ये हो गया. What is the mechanism of action of local anesthetic? Remember, एक तो सबसे पहले ये देखो, दो ये सोडियम चैनल्स होते हैं, ठीक है, सोडियम चैनल्स होते हैं वोल्टेज गेटेड. दीज आर प्रेजेंट इन 3 फॉर्म्स, ठीक है. एक तो होता है रेस्टिंग, एक होता है एक्टिवेटेड और एक होता है इनएक्टिवेटेड. रेस्टिंग स्टेट में क्या हो गया, दोनों के दोनों गेट क्लोज होते हैं, ठीक है, इसलिए इनफ्लक्स ऑफ द सोडियम डज नॉट हैपन. जब इम्पल्स होता है तो क्या होता है, ये सोडियम चैनल्स एक्टिवेट हो जाते हैं और ये ओपन हो जाते हैं, उसकी वजह से सोडियम इनसाइड हो जाते हैं. बट ये जो सोडियम चैनल्स हैं, they are open for a very short period of time, they are open for very short period of time, that is around 1 millisecond, ठीक है, they are open only for very short period of time. तो क्या होगा, आफ्टर 1 millisecond ये जो है, ठीक है, ये बंद हो जाएंगे. one of the gate they have upper and the lower gate, they have upper and the lower gate. So the upper gate gets closed, ठीक है, the upper gate gets closed, ठीक है, they become inactivated, मतलब even they are in refractory period, they are in refractory period. Even if the impulse comes, there is no influx of the sodium, so that means they go into the inactivated phase and from inactivated they will go back to the resting phase, ठीक है. तो ये जो local anesthetics हैं, they are able to act more on the activated sodium channel than the inactivated sodium channel, than the resting phase. So therefore I am saying that the local anesthetics, ठीक है, they are frequency, क्योंकि फ्रीक्वेंसी इसलिए जितनी बार हम उसमें स्टिमुलस डालेंगे उतनी ही बार सोडियम चैनल्स ओपन होंगे, ठीक है। तो इसलिए दे आर फ्रीक्वेंसी एंड टाइम डिपेंडेंट ऑल्सो, because the sodium channels are open only for a very brief period of time. एक ये पॉइंट समझ में आया? ओके, नाउ लोकल एनेस्थेटिक्स, ठीक है। सी दिस डायग्राम, दिस इज द ECF. इधर जो pH होता है दैट इज अराउंड 7.4, इनसाइड इट इज अराउंड 7.2. नाउ लोकल एनेस्थेटिक, दीज आर वीक बेसिस, ठीक है। तो वीक बेस बी है, ठीक है। These are weak bases. Now what they will act with the hydrogen ions and convert into the ionized form, right? Now as they are weak bases, इनका जो pKa होता है that is the dissociation constant in which the ionized and the non-ionized form is equal, that is 50%. pKa is around 8 to 9, remember this, ठीक है। तो इसके लिए तो ये एसिडिक मीडियम हो गया बिकॉज द pKa is 8 to 9, so more of it is present in the non-ionized form than in the ionized form. But it is only in कोई भी ड्रग मेम्ब्रेन को किस फॉर्म में पेनिट्रेट कर सकता है, कोई भी ड्रग किसी भी मेम्ब्रेन को किस फॉर्म में पेनिट्रेट कर सकता है, दैट इज इन द नॉन आयनाइज्ड फॉर्म, ठीक है। सो इट इज इन द नॉन आयनाइज्ड फॉर्म, ठीक है। द लोकल एनेस्थेटिक कैन पेनिट्रेट द मेम्ब्रेन, इट कैन नॉट पेनिट्रेट इन द cationic फॉर्म, ठीक है। वंस इट हैज पेनिट्रेट द मेम्ब्रेन, यहाँ पे 7.2 pH है, ठीक है। It will act with the hydrogen ion and convert into cationic form, and it is this cationic form which blocks the sodium channels, which blocks the inner gate of the sodium channel. Is it clear, Dr. Ehsan, Dr. Vikrant, Dr. Sejal? Is it clear? So the mechanism is, remember, they are weak bases. They penetrate the membrane, they will penetrate the membrane only in the non-ionized form, but they will block the sodium channels only in the ionized form. This is very important point, okay. And the action is frequency and time dependent, okay. And the okay, and it is frequency and time dependent. Is it clear? Any doubts in this? Any doubts in this? Now, how can we improve the penetration of the local anesthetic? Problem क्या हो रहा था, यहाँ का pH 7.4 है, अगर मैंने बाहर का pH increase कर दिया तो more of it will be present in the non-ionized form. So that can be done by adding soda bicarb with local anesthetic. उससे क्या होगा, बाहर का pH इंक्रीज हो जाएगा and local anesthetic will be present more in the non-ionized form, and it can easily penetrate the membrane, Is it clear? And अगर जब हम लोग बोलते हैं कि पेशेंट को इन्फेक्शन है या फिर वहाँ पे पस है तो लोकल एनेस्थेटिक इजीली एक्ट नहीं कर पाएगा. व्हाई इज इट सो? जब पस है, इन्फेक्शन है, तो उधर का इन्वायरमेंट का पीएच क्या होगा? इट विल बी एसिडिक पीएच. तो एसिडिक पीएच में क्या होगा? लोकल एनेस्थेटिक विल बी प्रेजेंट मोर इन द आयनाइज्ड फॉर्म and therefore it won't be able to penetrate the membrane and therefore उसका action will be delayed. ठीक है? Any doubts in this? Now coming to the fifth question. Dr. Sejal, are you able to understand? Okay, please answer this. The structures which are pierced in lumbar spinal puncture are all of the following except. This will be the last question we will discuss today. Okay, because I think so much information. First to revise these 5 questions and then we will continue tomorrow. Okay, with the previous year FMGE questions on regional anesthesia only. Okay, so now please answer this. Structures which are pierced in lumbar spinal puncture are all of the following except A. Ligamentum flavum, B. Dura mater, C. Supraspinous ligament, or D. Posterior longitudinal ligament. The structures which are pierced in lumbar spinal are all except A. Ligamentum flavum, B. Dura, C. Supraspinous, or D. Posterior longitudinal ligament. Okay, Dr. Kunal has given D as the answer. Dr. Kunal has given D as the answer. Others, yes, it is D. Yes, it is D. So, what are we piercing in case of spinal anesthesia? What are we piercing in case of spinal anesthesia? So, from outside to inside. From outside to inside, from posterior to anterior, what are we piercing? First, we are piercing the skin, then subcutaneous tissue. ठीक है, उसके बाद क्या होगा? स्किन, सबक्यूटेनियस टिश्यू, स्पाइन्स. ठीक है, स्पाइन्स का ऊपर का लेयर दैट इज सुप्रास्पाइनस. ओके, सुप्रास्पाइनस लिगामेंट. Okay, then we will pierce the interspinous ligament, okay, in between the two spines. Then we will pierce a membrane which gives a grating feeling, that is ligamentum. Okay, ligamentum flavum. Please remember this. Please remember this. We will pierce the ligamentum flavum, and after piercing the ligamentum flavum, we will have loss of resistance like feeling. We will have loss of resistance like feeling, that is ligamentum flavum. जैसे एक कार्डबोर्ड से एकदम से निडल को हमने पियर्स कर दिया हो, ठीक है, दैट इज लिगामेंटम फ्लेवम. आफ्टर दिस, इसको पियर्स करने के बाद we will enter into the epidural space. ठीक है, and if I am injecting my drug into the epidural space, ठीक है, where I have got the loss of resistance like feeling, then that is known as epidural anesthesia. It is a free space. It is an empty space. ठीक है, and as because there is negative pressure, we have a loss of resistance like feeling, and that is epidural anesthesia. उसके बाद अगर हम लोगों ने ड्यूरा मैटर को पियर्स किया, और उसके बाद हम लोग ड्यूरा मैटर को पियर्स करके कहाँ जाएंगे? ड्यूरा मैटर को पियर्स करके सब ड्यूरल स्पेस. ठीक है, and then we pierce the arachnoid matter. ठीक है, and enter into the subarachnoid space. It is the space, this is the space, remember, subarachnoid space is the space in which the CSF is present, and in this CSF what are floating? The spinal nerve roots are floating. So if I am giving my local anesthetic into the CSF, that is in the subarachnoid space, then it is known as spinal anesthesia. Then it is known as spinal anesthesia. Is it clear? Is it clear? So the structures which are pierced in spinal anesthesia from outside to inside is skin, subcutaneous tissue, supraspinous, interspinous, ligamentum flavum, remember, entering into the epidural space. If I'm injecting my drug into this empty space, that is the epidural space, we will have epidural anesthesia. Then we will pierce the dura, subdural, arachnoid matter and enter into the subarachnoid space, and where CSF is present, then we will have spinal anesthesia. Then it is known as spinal anesthesia. Now, as we are giving the spinal anesthesia in subarachnoid space, it is also known as the subarachnoid block or intrathecal block. So, out of these four options, we are piercing ligamentum we are piercing dura, we are piercing supraspinous, but we are not piercing the posterior longitudinal ligament. Okay, is it clear? Any doubts in this? Any doubts in this? So guys, today we'll discuss these 5 questions, and tomorrow we will continue with our class. Okay, tomorrow we'll continue at tomorrow we'll continue with the MCQ session at 4 p.m. Okay, at 4 p.m. on YouTube, and we will continue with the regional anesthesia previous year questions that has been asked in FMGE. Okay, so that was all for today's class, and on the Telegram app we have a channel t.me on NEET PG live. Please download the Telegram app so that you will get the access of when are the classes held. Okay, when are the classes held, what is the schedule of the classes. Okay, so tomorrow we'll have a MCQ session at 4 p.m. Remember, tomorrow we'll have at 4 p.m. on YouTube. Okay, and as I told you earlier, the advantages of getting the Unacademy Plus subscription. To get the Unacademy Plus subscription, you have to install the Unacademy Learning app, and then you have to select the NEET PG and get the plus subscription. Okay, and get the plus subscription, and that subscription you can get for 12 months or 24 months, and if you apply the code that is Apoorva Live, APOORVA Live, you can get 10% discount on the same. So the advantages I told you earlier in the beginning of the class, the daily live classes, you have structured courses which will help, and also mock test and analysis which will help you to crack the exam. And on the YouTube we have a channel NEET PG. Please subscribe to it, click the bell icon, like and share, and use my referral code Apoorva Live to get 10% discount on the same. Is it clear? Any doubts? Okay, so that was all for today's class. Tomorrow at 4 p.m. we'll continue with this class on FMGE questions. Okay.